Hi everyone, my name is Egwuma and I am a digital health consultant with KNCV Tuberculosis Foundation in the Netherlands. My background is in engineering and technology, and I have worked in countries with low resource settings, bridging the gaps between technology and public health. My presentation today is on the accuracy, acceptability, and feasibility of 99DOTS, a digital adherence technology to support TB treatment in rural Tanzania. I will be presenting today on behalf of my colleagues, Baraka Onjare and Lucas Shelogo in Tanzania, and Jens Levy in Netherlands. Tuberculosis is a communicable disease that is a major cause of ill health and is one of the top causes of death worldwide and the leading cause of death from a single infectious agent ranking above HIV/AIDS. Over 90% of TB patients are adults, and without treatment, over 70% of these patients will die. Additionally, TB is a disease of poverty and economic distress, and people who have TB are typically faced with stigma and discrimination. We know that TB is curable and preventable with a 6-month drug regimen. However, drug adherence is essential for this treatment to be successful. Poor TB drug adherence may decrease treatment effectiveness by 50 to 80%. And in Tanzania, although the national treatment success rates are high as 90%, the national average treatment success is still lower among the patients in the artisanal mining populations, which is where this study was done. In order for us to meet the global TB targets set in the Sustainable Development Goals of 40 million people treated for TB from 2018 to 2022, innovative steps must be taken. Digital adherence technology is an innovative step to support TB treatment, support patients for TB treatment. The goal of the project is to evaluate 99DOTS platform as a useful tool to improve TB treatment outcomes and also to address the global evidence gap for the use of digital adherence technology. To do this, the study was designed with 2 objectives. Objective 1 is to determine the positive predictive power, that is the accuracy of the 99DOTS for actual treatment dosing amongst patients. Objective 2 is to assess the acceptability of 99DOTS by patients and healthcare providers and the feasibility of using this technology to support TB treatment. For Objective 1, which was to determine the accuracy of 99DOTS, only adult DSTB patients were enrolled on the study, and the urinalysis was done using the ISO screen assay test kit to test for the presence of isoniazid, which is the main ingredient in the TB medication. The ISO screen assay test kit is proven to have a 95% sensitivity and 98% specificity. For Objective 2, which was to assess the acceptability and feasibility, adult DSTB patients and healthcare providers were surveyed through qualitative and quantitative interviews, and patient adherence data was collected from the 99DOTS platform. Prior to the start of the research, patients were enrolled on the 99DOTS platform for up to 12 months, and the study was done in 11 facilities in the Geita region of Tanzania. As I earlier explained, Geita region of Tanzania is predominantly a small-scale gold mining community where people are typically exposed to environments that have a high risk of causing TB. As shown in the previous slides, patients were enrolled on the 99DOTS platform for up to 12 months. A total of 992 patients were enrolled during this period. Of this 992 patients, 200 patients consented to participate in the research and were interviewed as part of Objective 2. Of the 200 patients, 197 patients were further randomly sampled for urinalysis. They were selected based on the adherence. Patients were categorized as adherents if they had logged a dose on 99DOTS platform 48 hours before the urine samples were collected, and non-adherent if no dose had been logged. For both categories of patients, adherent and non-adherent patients, their urine samples were collected and tested for the presence of INH using the IsoScreen assay kit. Based on this approach, 145 patients were categorized as adherent and 52 as non-adherent. For the healthcare workers, a total of 70 healthcare work providers were interviewed across the 11 facilities. To determine the findings for objective 1, which was to determine the positive predictive power of 99 dots, the positive predictive value of 99 dots was seen to be 95%. This indicates that 145 patients who had logged a dose on the platform 48 hours before the urine analysis, 138 of them had their urine samples test positive for INH. This indicates that out of the 138, out of the 145, 138 patients who logged the dose on the platform actually ingested their TB medication, which is 95% of these patients. Additionally, of the 52 non-adherent patients who did not log a dose 48 hours before the urine analysis was conducted, 41 of them had their samples test positive for INH. Thus, we see that the negative predictive value of 99 dots is much lower, 21%. In summary, we can say that 99 dots was 95% accurate in the prediction of patients who logged the dose to have actually taken the medication. However, we see that it is difficult for technology to determine if a patient who did not log a dose on the platform truly did not take their medication. When we look at this data by stratification of patients' month of treatment, we see that the highest match of 99 dots platform and the urine analysis was seen in patients on the first 2 months of treatment, indicating that patient engagement with the technology slightly declines after the first 2 months of treatment. For objective 2, to assess the acceptability of 99 dots, a Likert scale of strongly agree to strongly disagree was used to assess the patient's acceptability of the tool. And we see that in this case, 98% of patients found that 99 dots was very easy to use and they were comfortable using it. 98% of the patients said they liked the 99 dots reminders and it helped them remember to take their medication. 97% of patients said their healthcare provider communicated much better with them using the 99 dots platform. Another 97% said they made fewer trips to the clinic using 99 dots. 98% of patients felt like using 99 dots will help them complete their treatment. And another 98% also will recommend 99 dots to family or friends who are on TB treatment. 2% of patients were concerned they will be stigmatized if seen using 99 dots. And this ties back to what we earlier said about 99 dots, about TB patients experiencing stigma and discrimination. 10% of patients felt it took too much time to use 99 dots. For objective 2, with healthcare providers, we saw that 100% of the healthcare providers found 99 dots very easy to use and were comfortable using it. 88% of the healthcare providers said their patients using 99 dots visited the facility fewer times than other patients who were not using 99 dots. 94% of healthcare providers said using 99 dots decreased their workload, and all healthcare providers said using 99 dots improved quality of care they provided to their patients. 88% of the healthcare providers said using 99 dots makes it easy for them to identify patients who had not taken their TB medication as prescribed. And all healthcare providers said the 99 dots reminders or notifications which came up on their phones or on the application reminds them to follow up with their patients. All healthcare providers also said it was easy to teach patients to use 99 dots as a part of their TB treatment. We also did some analysis into the patient dosing history, to understand how treatment adherence impacts patient treatment outcomes. The scatter plot that is shown here shows the intensity of the color based on the amount of time a patient, which is depicted by a single dot, engaged with 99 dots. The deep red color indicates that more time was spent, while the deep blue or purple indicates less time was spent, while the gray color shows patients who did not engage with the DAT. We see that the cluster of deep red is seen as is expected, where patients completed their treatment and also where patients had treatment outcomes assigned as cured. While a large cluster of deep blue are seen where patient treatment outcomes are not evaluated, indicating that the healthcare workers had not assigned any treatment outcomes to these patients. We also see that in those who were not were lost to follow-up, about 93.5% actually had less engagement with the platform as well. In conclusion, we can say that the accuracy of the 99DOTS platform in predicting actual medication intake was very high in this study. It was a positive predictive value of 95%. The technology was also acceptable among patients and among healthcare providers. However, the feasibility of 99DOTS in Tanzania is dependent on using a completely toll-free line. So some changes to the infrastructure as to what was set up here, where patients are not charged and do not need to have a minimum airtime balance on their phone in order to communicate with the platform. We also see that it is important that other forms of digital adherence technologies which do not require mobile phones, such as the smart pill box, should be implemented alongside 99DOTS. This is due to the poor mobile phone penetration in Tanzania, rural Tanzania, which is roughly about 50%. Looking at the way forward, the Unitate funded Accent project, which is Adherence Support Coalition to End TB, aims to make digital adherence technology available to all patients. KNCV is leading the implementation of this project in 5 countries, and it will address current access to barriers to this technology, such as the demand, the adoption, affordability, supply, and delivery. These countries have been selected so that the project covers as much diversity as possible in infrastructure and patient population, treatment support, and economical situation, so that we can better understand how we can provide digital adherence to technology across different contexts and settings. The project, which commenced in 2019 and will run up until 2022, will also do some critical research. Alongside creating a global market and implementation plan for digital adherence technology across different types, which will be the medication sleeves, the smart pill box, and video-supported treatment. We'll also be doing some research to measure the effectiveness of DATs with a differentiated response to patient adherence on improving patient outcomes. We'll be conducting a process evaluation to understand causal mechanisms and contextual factors associated with success of interventions or otherwise. So we'll be looking deeper into the acceptability and feasibility of DATs among TB patients. We'll also be looking at the health equity impact, which is critical to the health system, and the cost effectiveness of scale-up of DATs with a differentiated response to patient adherence. As a secondary goal, there will be some impact modeling to measure the impact of DAT scale-up with real-time monitoring and differentiated care when compared with the standard of care in countries. Thank you. I'll be happy to take any questions you may have at this time.